Okay, I think we've given people enough time to join the call. So it's my pleasure to welcome you to today's webinar series. So thanks very much for all of those who are joining us today. We've got quite a busy agenda and very exciting talks from different countries, and we'll be hearing shortly from them. So thank you very much. So Rebecca, if you want to, yeah. So today we are very excited to be able to share some learnings on the implementation learning seminar series, and just to flag that this is the second of those series, and there will be more lined up. So please keep watch on the upcoming webinars. Today's session is going to focus on health information systems. And I just wanted to highlight that this is part of the implementation learning toolkit, which also I think I would encourage people to have a look at. What you can see flashing on your screen, the different health system building blocks. This seminar series have been organized by the different health system building blocks that are linked to the NEST 360 UNICEF newborn toolkit that's been developed with many partners. So there's a wealth of information on the implementation toolkit that I would highly encourage people to visit. And also we very much welcome any input, ideas, and contributions to this learning toolkit as well. So we very much encourage and would like to hear from you if you have any thoughts or contributions as we go through this seminar series. So today, as I say, the focus will be on the health information systems, and we're going to be hearing several talks on how can we measure service readiness to address the inequality gaps and be able to track progress, especially towards the Every Newborn Action Plan targets. This is going to be an interactive seminar, and please feel free to post your questions in the Q&A. There's various members of the teams who will be able to respond to those questions. And then at the end of the webinar series as well, we'll be able to revisit any questions that have not been answered by the team. So in terms of an overview, so we'll be hearing about the core design of the NEST 360 UNICEF Health Facility Assessment tools. And Rebecca Penzias, who's based at the London School of Hygiene and Tropical Medicine, will be taking us through that. And then after that, we're going to hear some learnings from Nigeria, the Giants of Africa, and Dr. Oluwafemi James will give us some perspectives on how the country and especially the Ministry of Health is thinking about this implementation and the health facility assessments. And then we're gonna leap to Malawi to hear from Dr. Msandeni and Samuel, who are gonna give us some perspectives on how they've been able to do the health facility assessment in Malawi and the plans that they have going forward with that as well. And then at the end, we'll close with any question and answer sessions from the panels. So as I said, as you see that revolving wheel, it goes through the different health system building blocks. Today, we have a focus on information systems. And now without much ado, I'm going to pass you on to our first speaker, who's Rebecca Penzias, about the HFA. Over to you, Rebecca, and thank you.
Thanks, Eric. Excuse me. So before jumping into the health facility assessment, I wanted to highlight two key targets focusing on newborn health that are linked to this work. One is the Sustainable Development Goal 3.2 to reduce newborn deaths to less than 12 deaths per 1,000 live births in every country by 2030. The second is the Every Newborn Action Plan coverage target for 80% of districts in every country to have at least one level 2 inpatient newborn care unit by 2025. 90 countries are currently implementing these ENAP targets and associated targets for ending preventable maternal mortality. Coverage targets 1 to 3 on antenatal care, skilled birth attendance, and postnatal care are being measured using survey data. But at the moment, there's no way for countries to measure their own progress towards coverage target 4. And supporting countries in measuring their progress towards ENAP coverage target 4 is a gap that we're hoping to fill through this health facility assessment work. So thinking about what level 2 newborn care units actually need in order to be functional, we can look at the evidence-based clinical interventions from the WHO framework, organizing small and sick newborn care by levels of care. Level 2 plus the transition care includes the clinical interventions you see here in bold and links with the ENAP EPMM coverage target focusing on level 2 care. So how are we assessing service readiness for level 2 small and sick newborn care? NEST 360 and UNICEF facilitated the systematic development of a health facility assessment tool to assess standards-based service readiness with a focus on level 2 small and sick newborn care. The tool was co-designed by a multi-country group with inputs from more than 150 global and national experts. Feasibility of implementation was really important in the design, and the data can be collected by a team of 7 data collectors in just 1 day. And you can see here some of our fantastic HFA teams pictured during the trainings and the data collection. And I also wanted to flag that the HFA tool is available online on the Newborn Toolkit. The HFA tool is organized by health system building blocks adapted from the WHO framework. And the structure also serves as the organizing framework for some of the HFA analyses and also for the Newborn Toolkit. The HFA dataset is quite a large dataset with about 6,300 variables distributed across 11 different modules. Through NEST 360, we've conducted baseline HFAs at 64 facilities. And all of this data has also been shared back with facilities, including with management and neonatal ward staff through these summary and full reports, which I'll discuss a bit more later on. Given the 6,300 variables in the health facility assessment dataset, we wanted to summarize this data and quantify service readiness for small and sick newborn care. So the first analysis I'm going to go through uses the adapted WHO health systems building blocks as a framework to develop a standards-based score. And this is work that we've already completed, and I'll briefly present some of the results today. The second analysis uses the WHO levels of care and associated clinical interventions as a framework to develop a level 2 service readiness score. And this is work in progress, and today I'll outline our plans for this work. For the standards-based service readiness scores, all items required for service readiness of small and sick newborn care were included. Each item was scored on availability, or if relevant, on availability and functionality. So for example, nurses staffed on the neonatal unit were scored only on availability, but devices on the neonatal unit were scored on both availability and functionality. 0 points were allocated to each item if it was not available, 1 point if it was available, and 2 points if it was both available and functional. And then scores were calculated by health system building block with a percentage based on total score over the total possible score for that HSBB. And then each HSBB contributed equally to the overall neonatal unit score. And for the level 2 scores, we'll use a similar scoring process based on availability and functionality. So now I'll briefly present some of the results for these standards-based scores. Here's a box plot showing the standard-based scores by country. And this includes data from 54 hospitals. 10 hospitals used the pilot version of the health facility assessment tool, and we're in the process of scoring those. So the overall scores in all countries varied from 33% to 74%, but there is some variation both within and between countries. So for example, we can see that the scores across facilities in Kenya and Tanzania were a bit stronger overall than in Malawi and Nigeria. We can also see that there's quite a bit of variation between the facilities in Nigeria compared to the facilities in the other countries. And here we have a heat map showing scores for the 54 facilities. And each row in this heat map represents a neonatal unit or a facility. And each column shows the overall or the health systems building block score. And I know it's a bit difficult to see the actual numbers here, but the colors can be helpful to look at overall trends and identify gaps across the facilities. Scores of more than 60% are shaded light or dark green, and these are areas of strength for facilities. Scores of less than 20% are shaded red, and these are areas of improvement. And remaining scores between 20 and 60% are shaded orange or yellow. So as noted, the baseline HFA scores overall varied from 33% to 74% with some variation by country. There were also some interesting patterns across the individual health system building block scores. So for example, looking at the medical devices scores, most facilities were below 50% in all of the countries. And then similarly, looking at the family-centered care scores here, which were below 50% in most facilities in all the countries, though there was a bit more variation in the family-centered care scores, particularly between facilities in Kenya here and also facilities in Nigeria, as you can see here. So as we can see, the heat maps can be helpful in identifying gaps in service readiness for small and sick newborn care, and also areas of strength. And we'll see later on how our colleagues in Malawi are using these heat maps to identify actionable gaps with facilities. Now I'll outline the plans for the level 2 service readiness score using the WHO levels of care and associated clinical interventions as a framework. So NEST 360 is being implemented at scale in all central and district hospitals in Malawi in partnership with the Malawi Ministry of Health. So it will be possible to assess the status of Malawi for the ENAP coverage target for 80% of districts in every country to have at least one level 2 inpatient newborn care unit by 2025. With 28 districts in Malawi, hospitals and at least 23 districts need to meet criteria for level 2+ care in order to meet the target. And we know that all of these hospitals have level 2 neonatal care units, but are the units actually functional, and are they actually able to provide all elements of level 2+ care? So how do we plan to assess readiness to provide level 2+ care? This diagram shows the proposed 4-step process. So step 1 here includes selecting interventions at level 2 small and sick newborn care and CPAP for the transition. And then step 2 involves taking each individual clinical intervention and identifying all ingredients needed for provision of care and other health systems resources needed for that intervention. Step 3 focuses on using the newly released WHO standards for small and sick newborn care to extract relevant quality statement input measures for each intervention. And then in step 4, we plan to map these input measures to the NEST 360 UNICEF Health Facility Assessment tool. So to take CPAP as an example, we would include all input measures relevant to CPAP management, match them against the health facility assessment tool, and then score individual items on availability and functionality using a similar process as for the standards-based scoring. The input measures would also be reorganized into 3 categories, into provision of care items only, neonatal ward systems, and facility level health systems. And this reorganization would be done to help understand which items are needed specifically for direct provision of care for each clinical intervention, and which health systems resources must be in place in order to provide that care. In addition to the standards-based and the level 2 scores and analyses that we're working on, we also have a number of products and global goods associated with the health facility assessment. So as previously mentioned, the health facility assessment paper tools are publicly available on the newborn toolkit. The electronic data collection tools, training materials, and analysis code will also be publicly released on the toolkit this year. We've also provided individual facilities with heat maps, with 3-page summary reports with high-level content from the HFA, and also full reports with summary statistics on each health facility assessment variable. And the shell templates for these resources will also be publicly released on the toolkit this year. Now I'll pass to Dr. Femi James to discuss plans for national HFA in Nigeria. Dr. Femi James, are you with us?
Yes, I'm here. So hello, everyone. And glad to be here to do this. So I'm to speak for us on the plans that we have in Nigeria to have a national health facility assessment. We're excited that we are also here to be able to learn from what's been going on in other countries. So I need to start by first acknowledging the fact that The vision for this was battered by our involvement and leadership in the work that's being done on comprehensive newborn care, where NEST 360 is visible in the country, and then a number of other partners also coming in on that. So the National Newborn Assessment, the aim is to assess newborn care in the context of the health system in Nigeria. And we have primary objectives and secondary objectives. I hope I'm audible. Hello?
Yes, go ahead. Go ahead. We can hear you.
Great. So the primary objectives is to assess the existing support systems for delivery of newborn interventions in Nigeria, identify gaps in those systems in relation to the national standards, and then make appropriate to inform programmatic decisions. Secondary objectives is to assess the availability and functionality of existing services in relation to infrastructure, equipment, commodities, supplies, and supplies for delivery. That's the first objective. Second one, to assess the capacity of the available health workforce for newborn care in terms of numbers and in terms of the type of trainings they have received. The third one is to provide information for proper categorization of facilities into the appropriate levels of newborn care according to the signal functions that we provide. First, we want to explore the level of participation in newborn care, newborn health, and map existing partnership for newborn at different levels. Explore available financing mechanisms for newborn health across the levels, and then assess the quality of data system on newborn health and interventions. And lastly, to assess the existing infection prevention measures in the perinatal, postpartum, and neonatal periods. So I also need to quickly mention that in November 2021, last year, so the Minister of Health in Nigeria launched the National Guideline for Comprehensive Newborn Care, as well as the National Guideline for Basic Newborn Care. And this contains a set of standards that we realized that we need to know the capacity of the system to support the implementation and to also have as a baseline for implementing this policy. So there is a national newborn committee that the minister re-inaugurated. It has been inaugurated for the re-inaugurated also around last year in order to be able to address certain critical issues. Since in Nigeria, we found that over the past almost 30 years, our population level information showed that there's almost a flat line when we compare the neonatal mortality rates. So the real changes there. And so the assessment is critical to all those things that we need. So the study design, by way of methodology, the study design for this is a cross-sectional, multi-phase, multi-stage study, which is using mixed method design, involving sequential collection of both quantitative and qualitative data that will address the objectives. And so the sampling will be done in phases and then in stages. Let me quickly give a little information on the setting. Nigeria is more than 214 million people living in 37 states, distributed over 774 LGAs, and and almost 10,000 wards. And so what many people are familiar with as district, it's somewhat in between wards and LGA. Typically a PHC is supposed to provide level 1 care by design, a secondary facility level 2, and a tertiary facility level 3 and above. The design of the health system is now to focus on having one functional PHC per ward. previous distribution show that there are many PhDs in some wards, and many times many of them are not functional. So getting one per ward has been the focus for almost 5-6 years now. So we say PHC under one roof initiative from that. The secondary facilities around one per LGA per local government area, while the tertiary is one, at least one per state. So now to the approach itself, there are two phases in the study. The first phase is virtual, is non-contact, while the second phase is in person. And so while now the first phase, which is non-contact, is also divided into two. First being the stage one is the landscaping, use of self-administered questionnaires, which all functional facilities in the country, from level 1, level 2, level 3, including faith-based facility mission facilities, private facilities will be part of this. That's stage one. It's self-administered questionnaires. Then the stage two. So the aim is so that no functional facility escapes us getting such information from it. While stage two is virtual interviews to selected sites that are adjudged to be active based on the findings from phase one. So when all the information has come in from phase one, there's a criteria has been set up to screen away certain facilities, and then those that met those criteria will now be the one that will be, there will be somebody from the group, from the center, the team will do a virtual call, charges of those specific facilities. So that's for the virtual phase, which is phase one. Phase two is the in-person as physical assessment. And so this is also in two stages. And so there's the initial physical health facility assessment, which is the traditional health facility assessment. And somebody goes with the tool, goes to the facility, and goes and conducts the assessment. And so there's also a criteria to screen all the facilities that have been confirmed from stage two that they are providing newborn services. So those that have been confirmed are the ones that would be visited. And then by stage four now is a key informant interview, which is qualitative, of course. And essentially, there will be two states that will be picked in each geopolitical zone. I also need to quickly say that Nigeria also has a division, a political division of states into geopolitical zones, average of 6 states per geopolitical zone. So states within a geopolitical zone have similar geographical and demographic features. So the best performing and the least performing in each geopolitical zone is selected for the key informant interview. And to judge that performance will be from what has been found in the stage 3 physical health facility assessment. This will help us to understand the enabling factors and the barriers to provision of newborn care services in the country. And so also to state that the criteria, so the team also look at the criteria that could be used to separate those different levels. So like between stage 1 and stage 2, facilities that reported by themselves that they're not providing newborn services are going to be screened off. And then there are also certain interventions being looked at. For instance, presence of a space, or what do we call it, newborn corner for resuscitation. Also is part of the criteria to the presence of resuscitation device and the presence of suction device. Those three determine whether a facility will make it from stage 1 to stage 3. So stage 2, the physical interview, is to just confirm whether what has been reported in the self-administered questions is real by the interviewer. So there will be certain video element and picture elements. While stage 3 is the physical assessment, and by default, the team have decided to, the committee, the newborn committee, to have all the tertiary facilities in the country visited. Like I said earlier, that's average of at least one per state. So in all, we will be having less than 50 in that category. So that is that as far as the methodology is concerned. The tool that have been used, tools have been designed for each of those phases and each of the stages. And so the tools that most of us will be much more interested in looking at would be the physical assessment tool, which is largely drawn from the existing tools, like the NEST 360 UNICEF tool, which was used in the site where comprehensive care is already going on in the country. So there's a lot of value drawn from that. And then other existing tools in the system were also considered, basically to see that the objective of the assessment is met. So those are the that is the tool. And then if we look at the objective, we realize that those different aspects, the different modules contained in the NEST 360 UNICEF tool are, of course, or largely taken care of even within the tools, despite the fact that it's not as if the team decided to carry the tool entirely. But look at this, that all these components have been addressed inside this. So far, the tools have been developed, the protocol is ready, and we've just been able to secure internal approval within the ministry headquarters. So the next stage is to have stakeholders meeting, secure ethical clearance, and then let the assessment proper begin. So thank you. Thank you.
Thank you. Good morning, good afternoon, everyone. My name is Samuel, and I'm joined by Dr. Sandeni. So we'll take you through the HFA. In Malawi, we conducted the HFA in 2020, and as of now, we have shared the report with all the facilities, and we are working on on addressing the gaps that we have noted. As Rebecca has already mentioned, the HFA tool used in Malawi was also informed by the health systems building block. So each and every framework has got its own heat map. We'll share with you what was noted, the gaps that were unearthed during the assessment, and what we are doing together with the ministry, as well as together with the facilities themselves. We are doing together to make sure that we are closing those gaps. So next slide, please. So next, I will invite Dr. Sandeni to take us through the medical devices, lab, pharmacy, as well as infection. She shares the heat maps, what we found out, and again, as I've already said, what is happening on the ground so that we address those issues. Thank you. Over to you, Dr. Sandeni.
Thanks, Sammy, and good afternoon indeed to everyone. So when we looked at the medical devices, as the results came out from the HFA, as repeat what Rebecca said, so the red means it's an area of improvement, green meaning you actually may be doing okay, and then you've got your middle color being yellow and orange. And so if you can see, it's completely red on the workshop bit, that heat map. Very, very red, meaning we were really struggling in terms of the biomedical workshop, like people having a workshop and being able to actually use it and implement, work on devices and improve care. But the lab, surprisingly, was active. Yeah, the lab was there, but it's not good enough to just say it's there. Equipment is there, but the functionalities please note that blood cultures are not being done in most of these facilities, no lumbar punctures and no CSF, although that looks green. On the actual inquiry on the ground, these services were not really there. A huge gap was identified, and within the NEST team, there was a group that focused on this topic to look into areas of improvement and how we can progress as a team. Next slide, please. And then we carried on and looked at another interesting aspect, which is infection. And if you look at my chart there, there's the various levels of infection prevention. So there's prevention, there's detection and care. On the prevention bits, we're looking at whether the facility had infection control guidelines and hand washing guidelines. Yeah, and then we actually watched as we went, I was part of the team doing the HFA. So when we went into the facilities, we knew when they were supposed to be washing hands, for example, and watched whether they actually did it or not. And then on the detection bit, we were looking whether there was device-associated infections and also thinking through the hospital-acquired infections. And finally, on the care bits, we're looking at early diagnosis of infection. How can we improve that? How can we improve drug usage? As you know, there's also rampant usage of antibiotics irrationally. So using this data and coming up with ways of improving the antibiotic use. So if you look at my heat map, clearly the detection bit was still a huge gap. While the care bits where we're talking about improving, having an early diagnosis and using drugs rationally, at least those things being done on the ground. And so this is an area that I already talked about, that there was a group that combined this information to get out into the facilities and to discuss how best can we improve infection prevention practices, but also improve the diagnosis of these infections. As I say, there's no blood cultures, no lumbar punctures being done sufficiently for us to be provide. So it's work in progress. So far, there's been some improvements. There's some, like the part of the implementation toolkits, there's quite some more information, but there's still more activities happening on the ground as the teams go out on the quality improvement visits. So people are gathering with the leadership, with the management in the facilities and discussing that you've got labs, you've got the facilities. How best can you use these facilities to make things better in your settings? We really look forward to some changes and hopefully have a better HFA result at the end of the repeat HFA. Sammy, over back to you.
Thank you, Doctor. So next is about human resource. So as you can see on the heat map, what we noticed being the major gap was about staffing levels, people. This was as a result because usually, the facilities, the nursery ward was either under labor ward or postnatal ward. So what we advocated for is to make sure that the nursery ward is a standalone unit, and at least they allocate special nurses for that unit. So there was an additional employment of extra staff, but we just waited for the allocation of staff members. As of now, almost each and every facility has got special nurses for the nursery ward. At least 3 nurses to manage to cover the day shift, and the at least 2 nurses to manage to cover the night shift. Next slide. The next is about infrastructure. So infrastructure, the major gap in our facilities, as you can see on the heat map, is about medical gases and vacuum. And this was also noticed when the COVID-19 hit us hard. We only relied on the oxygen concentrators. So this is a major challenge and it requires a lot of resources. We cannot do it just over time. And again, apart from that, we also had a challenge when it comes to the design of the nursery ward. There was no standard way of constructing or renovating the nursery ward. Each and every nursery ward is different from one another. So we working with the Ministry of Health to come up with at least a standard design, a floor plan for each and every nursery ward that will be built going forward, and see to it that at least we are not separating the child and the mother in the course of the treatment. Next slide. The next one is about information systems. Information systems, the data collection bit of it is in place. The data management bit of it is also in place. However, we have issues when it comes to data for action, decision making using the data we are collecting. So you will notice that in the facilities, they are able to collect data, they are able to manage data, they are also able to transfer the same data, for example, in the DHS to in the HMI system. But how to use that particular data to make decisions, that has been a bit of a challenge. So what we started doing is that empower the facilities themselves to start conducting the readiness audits that is being done now, and they are also able to do NND audits and come up with change ideas out of the findings and come up with the projects that are being implemented in the facilities to make sure that they are able to use their own data they are generating on a daily basis. And we also do conduct collaborative meetings so that the facilities have got a platform to share how they are being able to use their own data for decision making, not just reporting in the systems. Next slide. So the other framework is about family-centered care. So we should admit as a country on family-centered care, when we did the assessment, there was nothing on the ground. Every facility was doing things their own way when it came to family-centered care. So for a start, we are also working with the Ministry of Health to come up with policies and guidelines that can at least inform the facilities on what to do when it comes to family-centered care as far as newborn care is concerned. Once that is in place, then we also have at least a system in place to see that these guidelines and policies are actually put into practice. This will be followed through the quality improvement visits we do conduct every quarter. KMC, we were actually doing good, or what was lacking is just some issues of follow-up and development care. And the addresses of now several facilities are at improving to make sure that actually once there is a discharge, they should be able to follow up with that particular newborn to the community. Next. So last three is about governance. During the assessment, what we actually noted, if you see on the heat map, is that at least the systems are actually in place. They are there. What was lacking was the functionality and coordination of them. So what we are trying to do to close that, we try to work with the Minister of Health as well, to rejuvenate, to revamp the system so that they start working as they are required to do. So just for example, we supported the ministry in making sure that the quality improvement support teams as well as work improvement teams in the ward, they are actually working. They are coming up with changes. Just for example, once they have done the audits, they have noticed some of the issues with what is killing the babies in the ward. They come up with changes and implement them with the support, with the quality improvement support team, and not forgetting the management team. And we are also making sure that these systems do operate within the structure, starting from the Ministry of Health itself to the district platform, right at the ward level. In that case, we are trying to advocate with the district teams to make sure that at least the issues to do with small and sick newborn care are incorporated within the district implementation plans or the central facilities implementation plan, so that whatever is being done within the facilities to improve the small and sick newborn care is sustained going forward. Thank you for your attention. That's the end of our presentation. Over to you, Eric.
Thank you. Thank you so much, Sami. And I'd like to also want to thank all of our speakers for today. Thanks so much, Rebecca, for giving us an overview of the NEST 360 UNICEF Health Facility Assessment Tool, which was co-developed by many country partners, and for giving us an overview of the tool, but also scoring, which has led to the work that's been presented on the heat maps and where the gaps are. Thank you, Femi James, for your presentation as well on the aspect in Nigeria, but more importantly, the plans for the National Health Facility Assessment. I can imagine that is a mammoth task for a country such as Nigeria. And also Drs. Sandeni and Sami for giving us an overview for Malawi and where the gaps are and what the team are doing in addressing some of the gaps that have been identified. Also wanted to reiterate that as part of these plans, the work that's been presented on the HFA is work that was done at baseline. And there is further work coming up next year to do an endline assessment in a very similar fashion across all those facilities, where we will be able to see what differences or what gaps or improvements that have been made between the HFA assessments at baseline and endline. So that's provides us a good opportunity to be able to see the progresses that have been made by the different countries. So thank you very much. And also thanks for keeping on time. So we have about 15 minutes for question and answers. And thank you for all those who've been posting questions as well in the Q&A. So I'm going to now move on to try and answer those questions, but also welcome discussions from the attendees today. So perhaps, and I'll probably start with the first question that was asked by Professor Ashok Diori from India. And this question particularly is regarding the HFA competencies. So Professor Ashok is asking, how can we assess availability of human resources? So thinking about the key bottlenecks that exist in LMICs for providing quality of care, is the focus based on the number of nurses and doctors, for example, or pediatricians in proportion to the number of beds, or is there some criteria which ensures the presence of skilled and competent professionals on the ground? So a question between the numbers versus competencies. And I wonder whether, Dr. Msandeni, you have any thoughts on this, if you could start us off, please. Msandeni, are you there?
Yes, I'm here. Just lost your connection a little bit, but can you repeat the question?
So the question is regarding the availability of human resources and whether, and obviously this has been flagged as a key bottleneck in LMIC for the provision of quality of care. So thinking about not just the numbers of nurses or doctors that are present, but also linking that to competencies. So do you have any comments on that? So from a HR perspective and staffing.
Yeah, so from an HR perspective, as you know, that NEST 360 is not really giving or working on improving the HR directly, but indirectly, as you improve the work environment, what we've noticed is that it increases the energy levels in the wards. Just people are excited and more hands-on and more excited. There's a lot of training that's happening. So we're not recruiting, but we've really worked hard to improve the levels of knowledge and competencies. As you know, there's also skills lab that people can use to refresh their knowledge. And also the trainings are starting from pre-service. So there's a lot of energy within the neonatal units at the moment, even without, a sharp rise in the actual number of human resource. The competence levels is where the NEST 360 program has really focused on. So that would be my comment.
Thank you, Msandeni. And I also like to flag that I know Dr. David Kadara is here, who's actually done lots of work on HR staffing levels and ratios, and is a very keen interest on this work. David, I wonder whether you may have some comments or reflections on this as well. David, are you there? Can you hear me?
Yes, Eric. Can you hear me now?
Yes, go ahead, please.
Sorry, I didn't have the mic. Yeah, so I think the HR work is really key, and I think an important starting point is just first having the numbers. Because even if you have people with the right competencies and they are not enough, then we won't really make a lot of progress. But and I think that's where the HFA is coming in as a starting point. And the recently launched WHO roadmap pretty much outlines that we need to focus on the numbers and then work on the competencies, recognizing that getting specialists in these settings can be challenging, and therefore they need to consider approaches like task shifting, where we work towards formal capacity building and curriculums for training formal staff within newborn units, like specialists, neonatal nurses, and neonatologists. Over.
Thanks. Thank you, David, for very helpful insights. I'll take this back to Professor Ashok. I know you've also been doing similar work in India. Do you have any kind of comments or reflections on this as well? I know it's a challenge.
Yeah, thank you for asking me. I think it's a challenge even in India. What we normally do is we do face-to-face training of people and then provide observership to them in a working, functional, good unit, so that they learn all the routines and the equipments which are getting used, SOPs which are being followed, and once they go back to their smaller units. But the challenge is, with the rapid turnabout of nurses and doctors from these smaller units, it is very difficult to keep on training the fresh lot time and again and build their competencies. It's a challenge which we also face in India. Thank you.
Thank you. Thank you. And I think as David has highlighted, as part of the NEST 360, I think we're trying to track the numbers of staffing levels that exist in these hospitals, but also the ratios and how those may differ by day and night, for example. But also even things like how often staff are moved from different units, existing competencies, and seeing how much that may affect the quality of care that's being provided. And there will be ongoing work to try and better understand how much staffing levels or ratios are, if you like, even indicative of quality of care. So I think there's a large body of work, especially in this area. And there is ongoing work that's going as part of 360 and other work streams that we are aware of. So we hope that at least will provide some insights towards this end. So so the next question, and this is I'm going to flag this to Dr. Femi James. So this is, I think, Jennifer Gilbertson is asking, when you compare information that is self-reported in a questionnaire to an in-person audit, do you see large discrepancies? So Femi, do you want to help take that question, please?
So thank you. I want to appreciate Gilbertson for that question. So there are studies that have shown almost no significant difference in findings from those conducted on self-administered question and the physical interviews. But why we decided to have this two-stage for the Nigeria plan activity is that the second phase, in addition to confirming some of the entries made in the first phase, there are a few additional information that interested in that would also help to properly categorize the centers. And the first phase is going to cover almost 10,000 centers. If you see one PhD per ward, the secondary and the tertiary. So that's huge and almost unmanageable to want to do physical interview to all. And so the second phase is to now help to narrow down and get those added value from it. So that's why we decided to go that route. We understand that the virtual interview now is a self-administered questionnaire, especially now, has been that methodology has been so perfected that you can almost get almost all what you need there. So we decided to go that extra mile because of the extra information needed. Thank you.
Thank you. Thanks, Dr. Femi James. We've got another question, and this is, I know I've seen Sarah Collins is on the call. I'm sorry to put you on the spot, but the question from Charlotte is, how are we assessing rational antibiotic use? I wonder if you have some comments, Sarah. I know you've been doing some important work with James on this.
Yes, hi everyone. So what we did, or in the process of doing, is actually mapping antibiotic use against the AWARE classification, which was released by WHO, I think, at the end of 2017, 2018. And what we've seen so far, that there's just a high level of use of what is termed as watch antibiotics across most of the facilities implementing NEST. And what we think will be really interesting to look at, and I think some of the work that's been released by GUARD DP is actually more around, it looks like facilities are observing that there's resistance and changing the antibiotics that they use, as opposed to staying on the access, or like what we call like the green use antibiotics. So I think it's going to be really interesting to see, kind of align that with the findings from the neonatal inpatient data set to what's actually the experiences on the ground. I hope that's helpful.
Thanks. Thank you. Thanks, Sarah. There's another question I think is very important from John, asking how have we found the process of feeding back data that we've collected to the units, both in terms of the hospital management and clinical staff, when they're appearing in the red, in quotes, categories, usually due to wider system challenges, so rather than individual or facility departments. So again, the feedback mechanism for the HFA, for example, which has already been fed back to the facilities, with the country teams. And I saw Christine on the call. I don't know if Christine is able to comment, and then maybe we could also hear from the country teams in Malawi as an example to hear if they've got any thoughts on this. Christine, if you're there, do you mind commenting on the kind of feedback process back to the countries, especially the flagging of the red, in quotes, areas where the facilities are not being highlighted to do very well?
Sure. Hi, everyone. So I'm sure our country representatives on the call will have much more to say about this, but I can just frame a little bit about what we've tried to do across the countries. So we've tried to not just hand back a big fat report of 80 pages to the facilities and leave it there. We've discussed all of the findings and the implications as part of collaborative review meetings with representatives from the neonatal units, from the facility management, and from the national ministries of health. And we've done this very much in the spirit of our quality improvement initiatives across NEST that are very much focusing on how can we take these learnings and how can we improve, and not built around blame culture. So I think there's, of course, always ways in which we can improve communication back to the facilities, but I think really trying to report this data back in an actively and engaged way so that facilities actually see this as an opportunity and get excited about where they can start through other initiatives like mentorship, through quality improvement visits, through ordering of new devices, et cetera, to start tackling some of these gaps.
Thank you. Thanks, Christine. I don't know if anybody from Malawi would like to provide some insights as well. Sandeni or Sami?
Yeah, maybe let me just go ahead, Guru. Go ahead.
No, you go for it, Sami. Yeah, thanks.
All right, let me start, then Doc will come in. Thank you for the question. For a start, before we send the report back to the facilities, we started with a dissemination of the results. So we shared the results with key people within the Ministry of Health so that they can look at the results first before they go spreading. Once they give us the green light, then we do the dissemination of the same results to the facility level through the collaborative meetings that were being conducted at the zonal level. So soon after the collaborative meetings, when the team members from each and every facility agreed to the results, that's when we disseminated the results now at the very bottom level, the facility level. So most of the facilities, if not all, agreed with the information or what the results were showing, and they are very much committed to work on the gaps that were noted. Though a few areas whereby, because of the gap between the assessment and the dissemination of the results, some things already changed. So those areas were flagged out to say that shouldn't be an issue altogether, because the issues were already addressed. So yeah, briefly, the results were welcomed, and they really agreed that that's what was really on the ground as far as small sick newborn care is concerned. Thank you. Over to you, Doc.
Honestly, I have nothing much more to add. I think it's as is, as Christine has explained and Sammy are saying, but just an emphasis from my end is the fact that I'm really learning that the quality improvement initiatives have so much potential to do more as we are starting to implement that, asking the facilities to pick their problems and prioritize them and use it as a quality improvement initiative. I'm seeing that it's something that we need to focus a bit more on, and that they can use it more going ahead in order to cover some of these gaps that we saw in the HFA.
Thank you. Thank you all for those great insights. And then I think there was a comment again here from Professor Shock, but it was regarding the hubs, creating mentoring hubs, which I think is something that we're already doing as part of NEST. And I'm sure if there is time, we can speak a little bit about that on some of these mentoring hubs that we have with some of the countries. I also like to highlight that today you've only heard from 2 of the NEST participating countries, so Malawi and Nigeria. But just to highlight that obviously there is we're also working in Tanzania and Kenya, for example. So there's a lot of learnings across different countries. Please feel free to reach out to us for more information. And thanks to those who are putting questions and comments on the chat. And also the implementation toolkit is a very, very good learning resource which has more information. So in the interest of time, I just wanted to flag to say thank you so much for joining us today. And on the slide, you can see links which you can visit, where you can see the toolkit, which has more information about the eight health system building blocks. And also there's a newsletter with a link which you can sign up if you want to be able to receive updates on any new materials and upcoming webinars. And also just to flag that next week, there will be a similar webinar, which is going to be focusing on human resources. So again, we touch on that a little bit. So there will be a session next week as well, a similar webinar, whose focus is going to be on human resources. So feel free to sign up, and we hope you can join us next week. I'd like to stop there and thank our speakers again, and thank you all for attending today's session. Thank you very much.